you know, learn, learn the advanced part, learn the advanced part of this class. So that is the aim, for you to learn the basic, then you can now add the advanced part of it. So can somebody just volunteer, try from the beginning what we have been talking about, the sequence of attending to a patient that have come to accident and emergency unit. You can follow that sequence to where we stopped the other time. Guys, I'm waiting for you guys. Somebody should just volunteer and just list, not going into, not explaining now in detail, just list from beginning what we have to do in each step, each stage that we are in. Can you guys hear me? If you can hear me, just type that you can hear me so that I will know that you can hear me. So I can see Temitope is online. Temitope, can you try? Just try. Or mute yourself and try. If you can hear me, kindly type that you can hear me so that we can move on. Okay, fine. If you can hear me, just type you can hear me so that we'll move on with the class.
Hear you, sir.
You can hear me. All right. So if you guys don't want to give it a try, no problem. Let us proceed. But you should know that the best way of learning is you learn by rehearsing what we have learned so far, trying to remember what we have learned so far. That is the best way. Now, the best way of learning. We learn to rehearse what we have learned, and as we do that, it tends to be part of us. All right. So with that being said, I want to just quickly run through the sequence that we have been talking about. So the sequence of attending to a patient that has presented to the accident and emergency unit as either a paramedic personnel or a physician assistant, which is what we now have. We now have it very common in the UK. Is physician assistant, which their job is exactly what we are doing now, to attend to the patient. They are the first health personnel to come in contact with patients. They will take history, they will resuscitate the patient, they will do examination, and they will start initial management, initial treatment that the patient needs, depending on the diagnosis they have made. So based on that initial treatment, then the doctor can now come when the doctor is much free. Physician assistant. Paramedics are the health personnel that are usually deployed to the community to attend to patients with acute medical emergency in the community. So the paramedics are those that go to the patient house. Maybe somebody has fainted, somebody has collapsed, somebody has a penetrating injury, somebody has a gunshot. They are the people that are the first people that are called. So they enter into the ambulance, drive the ambulance, go to the person's house, take brief history as we have spoken before, use ABCDE of resuscitation, resuscitate the patient, now take more history and now quickly transport the person from the house to the hospital to hand the person over to the doctors for continual management. So that is where the course you are doing now fall in. Paramedics, physician assistant, and other health-related personnel. So we were in a sequence which we started with. We said the first sequence of attending a patient in a medical emergency, or in a trauma patient is to take a brief history, which you previously stated that brief history constitutes of what happened. What happened to this person? He collapsed. That is it. What happened? What happened to this person? Oh, he was previously fine. All of a sudden, he collapsed. When did it happen? Because you want to know, has this been going on? Is this something that happened 6 hours ago? Is this something that happened 10 hours ago? When did it happen? Oh, just 30 minutes ago. Okay. How did it happen? Just like that. He was sitting. We're all fine. We are chatting. We are talking. All of a sudden, he collapsed. So this is just the brief history that we need. What happened? When did it happen? How did it happen? Just 3 words. When? How? Sorry, what? When and how? What? When? And how? So that is just what you need at that point in time. What happened? When did it happen? And how did it happen? After that, no more. You are not expected to ask anything more. You just have to swing into action by resuscitating the patient. Resuscitating the patient. For paramedic personnel, part of this resuscitation include what we call cardiopulmonary resuscitation. For cardiopulmonary resuscitation is a big topic on its own, which as emergency personnel, you take time, you will take maybe a day to cover that aspect. But the resuscitation we are talking about here is a general resuscitation, which does not include cardiopulmonary resuscitation. For emergency cases, a patient is gasping, a patient is dying, you would need to bring in your skill to do cardiopulmonary resuscitation, also known as CPR, cardiopulmonary resuscitation. So we'll cover that topic after we have covered what we have on ground. So try to cover that particular topic. Okay, so say the first thing is brief history. What happened? When did it happen? How did it happen? The second thing is resuscitation of patient using A, B, C, D, E of resuscitation: airway, breathing, circulation, disability and dextrose, and then exposure of the patient. We said after resuscitation of this patient, then we will now take a detailed history. And we have given lecture, we have learned about this detailed history. We have learned about this detailed history, which we said we are going to use 5 C's. 5 C's. The chief complaint, which is why did he present? Or what happened? What is the issue? Why did you come to the hospital? That is the chief complaint. And the second C is the cause, which we spell COURSE, which is when did this problem started? How long has it been going on? For example, in the last 2 weeks, is it getting better? Is it getting worse? What are the other associated symptoms that this person is also having? Okay, difficulty in breathing started 2 weeks ago. Okay, and the chief complaint here is difficulty in breathing, and the cause is when did it started? It has been going on in the last 2 weeks. Okay, is it getting worse? Is it getting better? It's getting worse. That's why the patient presents. Okay, what are the other associated symptoms that goes with this difficulty in breathing? Okay, he also has a lower limb swelling and also has abdominal swelling. And the patient said he can't sleep at night unless he puts about 2 to 3 pillows on his head before he can sleep. So all these things now they are pointing towards somewhere already for us. If you if you have experience in medicine, you would pick up what we are talking about right away. Okay, somebody presenting with difficulty in breathing 2 weeks, and this difficulty in breathing, that's chief complaint, difficulty in breathing. And this difficulty in breathing has been going on in the last 2 weeks, and it's getting worse. And the other associated symptoms include lower limb swelling, abdominal swelling, cough, and the patient cannot sleep well at night unless you have to put 2 pillows or three pillows. What is he trying to do? It's what we'll talk about in this examination. In this examination we are going to do today. He's trying to put himself in cardiac position. He's trying to pop up himself to put himself in cardiac position, because if he put himself in cardiac position, he will be able to sleep without having difficulty in breathing. He's going to put himself in cardiac position without having, so that he will decrease the difficulty in breathing he's having. Because when he's lying flat, we have accumulation of fluid. Fluid will start to zip out from the veins within the lungs. And as the fluid are zipping out from the veins within the lungs, they will accumulate within the lungs. You will see fluid, what we call pulmonary edema, chronic pulmonary edema. You see a lot of fluid gathering in the lungs when the person is lying flat. So they cannot be able to sleep. But when they put a lot of pillows, maybe like 3 pillows or 4 pillows on their head will pop up. So they will be lying at angle of 45 degree. So with that position, which is cardiac position, they will be able to sleep very well. So you get all of this history. Chief complaint is difficulty in breathing. And the cause is, it started 2 weeks. It has been getting worse. He has associated symptoms of lower limb swelling, abdominal swelling, cough, and inability to sleep at night unless he pop up his head with the back of his head with 2 pillows. So when you get this history, come on, you have a diagnosis. What is diagnosis? A diagnosis is heart failure. It's heart failure that will give that classic picture that we have given in this case now. Okay, so now you are done with your course. The next thing you are doing in the detailed examination is the cause. Okay, what is causing this heart failure? So you have to ask the risk factors of heart failure. Are you a non-patient with hypertension? Are you a non-patient with diabetes? I want to know, because hypertension is one of the most common causes of heart failure in our environment, Nigeria. So are you a non-hypertensive patient? Are you a non-diabetic patient? For how long? So that is the cause of the heart failure that you have made the diagnosis. So the next one I want to talk about is the complication. If there's any complication that have occurred since the patient started to be ill. And the last C is the care. What is the care that this person has received so far? Okay, since the 2 weeks that this problem started, he has bought so many medication in the pharmacy and he has been taking those medications, but he's not getting better. That is the care he has received so far. So the important things you want to talk about in the history now is that the person has been regular on any medication. If the person reacts to any drug, is there any drug that this person reacts to? And then if they also want to know if the person has allergy. And then don't forget the social history. Do you smoke? Do you drink alcohol? So that comprises the detailed history that we have talked about. And we said after having this detailed history, we have to go into examination findings. And we're able to cover general physical examination in our last class. What did we talk about in general physical examination? We said we have to examine the patient from head to toe using the inspection, palpation, percussion, and auscultation that we discussed in our last class. Why we say inspection simply means looking, to look and check if we are going to pick some signs. Palpation means touching. Auscultation means using our finger to percuss on the chest or the body of the person. And auscultation means using our stethoscope to listen so that we can pick up some sound that will tell us what the problem is. And we're able to say that in our general physical examination that we only need inspection and palpation. We don't do percussion, and we don't do auscultation. Okay, we're able to also talk about the sequence of examination, head to toe, when palpating, check for fluffiness of hair. After checking for hair fluffiness, we go into the eyes where we check for pale or for pallor, if the person is pale. Also in the eyes, we are going to check for jaundice, if the person has jaundice. And then we'll come back to the mouth where we're going to check for cyanosis, if the person is cyanosed. So we're also going to check within the buccal cavity if there are salivas, connoting the hydration status of the patient. So we now go to lymph node examinations on the neck and the axillary region. And we're going to check the palm of the patient for pallor and for finger clubbing. So, and then finally, we are going to go to the leg where we are going to check for pedal edema. So that comprises the general physical examination. So today now we are going to go into cardiovascular examination. We are going to examine heart and the pathologies that have to do with the heart. So having given a summary of what we have been discussing all of this while, since we started this class, we're now going to start our today main event with heart examination. So how do we examine the heart? The same sequence applies. The same sequence applies. The same, we have a mnemonic which we call grip, which is greeting. When you greet the patient, hello sir, hello ma, you establish rapport, grip, G-R-I-P, grip, grip, G-R-I-P. So grip, greetings, hello sir, hello ma, how are you sir? So when you greet, hello sir, good afternoon sir, hello ma, good afternoon ma, that is greeting. And we have the arodia, which is rapport. How are you sir? I'm fine, doctor, I'm fine, sir, I'm fine ma. So that is rapport. You want to establish a rapport. You want to get used to the patient. You want the patient to get used to you. And the idea is introduction. You introduce yourself. I am Mr. Paul. I'll be the one attending to you today. I'll be the one to examine you now. So that is introduction. And the pedia is permission. Hello, sir, can I examine you? Can I go ahead? So you seek for permission. And this group applies to all the examinations. So it's still the same thing we explained in the physical examination, but here we'll come up with a mnemonic for you to remember it. Grip mnemonic, the same way. I say you want to greet the person, you want to introduce yourself, you want to seek permission, you want to tell the patient to expose him or herself, you want to screen the patient because she cannot just open up the patient and you start to examine the patient. No. So you follow this sequence. Grip, greeting, rapport, introduction, permission. Then expose the patient, put the patient in an anatomic position, and screen the patient. Screen the patient, put the patient in an anatomic position, and expose the patient. Then you can start your examinations. Okay, before now I have emphasized that if you want to examine a patient, you must stand on the right hand of the patient. It's very important. So you must stand on the right hand of this patient. So the next thing, after you have done all of these things, is to put the patient in cardiac position. You want to examine a patient, always put the patient, you want to done any cardiovascular examination, you first put that patient in cardiac position because you don't want the person to feel uncomfortable while you are doing the examination. So put the patient in cardiac position. So what are the things that we are going to examine in a patient? Well, some vital signs are important. We are going to start with pulse. We are going to examine for cardiovascular examination. Pulse for cardiovascular examination, pulse is the first thing that you are going to examine. Now, the pulse that you are going to examine, the pulse that you are going to examine in cardiovascular examination is not the peripheral pulse. Because peripheral pulses examination are a topic on its own because it's wide. So the pulse you are going to examine here include the radial pulse and the femoral pulse. So those are the only two pulses you are going to examine in cardiovascular examination. All other peripheral pulses are more detailed. So that one will be a class on its own because it has a step, a sequence which it must be followed. So we're going to examine the pulse. The pulse is the first thing. But before you examine the pulse, remember that you must, because pulse consists of palpating, you will touch the patient. So before you touch the patient, you must inspect. Remember that we are following IPPA, inspection, palpation, percussion, and auscultation. So what is the catch here? The catch here is that in cardiovascular examination, we do not percuss, but we must inspect, we must palpate, and we must auscultate. So during your examination, when you're taking your examination, you might get a question, which of the following is not done in cardiovascular examination? Well, you need to know what is not done. You need to know which of the following thing is not done in cardiovascular examination. In general physical examination, we might must ask you in your exam, the exam that you write at the end of this whole course, would ask you, which of the following is not part of general physical examination? You should be able to know inspection, palpation, percussion, auscultation. Which one is not part of the general physical examination? So the same applies to cardiovascular examination. Which part is not among the inspection, palpation, percussion, and auscultation? Which one is not part of the cardiovascular examination? Is it inspection? Is it palpation? Is it percussion? Is it auscultation? Well, I'm telling you, percussion is not part of cardiovascular examination. So before we start to examine the pulse to palpate the patient, we must inspect. So the same sequence, inspect the head of the patient by just looking at the head, look at the chest very well. It's going to help you. So looking at the chest, you are looking for scars, you are looking for pigmentation, you are looking for anything that suggests if the patient have had surgery, maybe cardiac surgery in the past. So you go down to the abdomen, you're also looking, go down to the leg, you are also inspecting to see if there's anything that are obvious. You also take notes. If there's anything that's obvious, and take note of. So after that, you are now going to go into post-examination. After giving this class, I'm going to play a video which you'll see the sequence. This video is from a doctor, one of the resident doctors in Nigeria, that formed that video. So it's typical of how we do cardiovascular examination in Nigeria, just that he added some additional things which are probably done in his center alone, which are not generally done in other centers. But it basically covers everything we do in teaching hospitals in Nigeria. So I'm going to play that video after giving you oral orientation on how to go about examination findings. After playing that video, I'm also going to send it to the page for you guys to also watch the video so that you can get used to what we are talking about. So I'm trying to put up something. I'm trying to put up an image. All right, so sorry for the interruption. So, hello, can anybody see my screen?
No, sir.
You can't see my screen?
Yes, sir.
Okay, let me try and see. Can you see it now?
No, sir.
We can't see it, sir.
But can you see me? Like, can you see me?
No,
It's happening to me. All right, let me try and
pressing it or something.
Try and refresh it, sir.
I'm trying to do that now. Thank you.
Sir.
Okay, can I be seen now?
Yes, sir, we can see you, sir. You can't see me.
You can see me, Abby?
Yes, you are showing.
Okay, so I want you guys to just have a moment to just look through your WhatsApp page, the WhatsApp page. Yeah, you see an image I sent in that place about the post examination. Can you see it?
Yes, sir. We can.
Yes, sir.
Okay. Okay. So we're still going to play a video. I just want to give you the overall idea.
Thank you very much.
On how the examination follows. So first of all, if we want to examine cardiovascular examination, we follow a pattern which we said we are going to go from. Hello, guys.
Yes, sir.
Okay, we said we are going to follow a pattern. The pattern we follow is we follow a pattern from the wrist, which is the pulse. We check from the wrist, which is the pulse. We go upward to the arm, which is the blood pressure. So in that fashion, you must follow that pattern. From the wrist, which is the pulse, you go upward to the arm, which is the blood pressure. So after the blood pressure, you go to the neck of the patient, which is the jugular vein, or the neck vein. So I want to look at the neck vein. So at the wrist, we are checking for pulse, and we use the radial artery, which we are going to. That's where the image I posted. That's the artery there. The artery that is located at the wrist is called the radial artery. Radial, RADIAL, radial artery. So that's where we check our pulse for cardiovascular examination. So after checking the pulse at the radial artery, we move upward to the arm, where we check our blood pressure. In that sequence, and when we'll be reporting it, we'll be reporting our cardiovascular examination in that sequence. So after examining for the BP at the arm, we move upward to the neck, where we're going to look for neck veins. are the neck veins distended or not? Because if they are distended, they are telling us something. The patient is likely in heart failure. If the neck veins are distended, the patient is likely having heart failure. So after checking for the neck, the next thing we are going to come to is what we call the precordium. So the precordium is simple, the anatomical space where the heart is located in the chest. That region of the chest that is occupied by the heart is what is called precordium. So somebody might just tell you, examine the precordium of this patient. The person is just telling you, examine that surface of the chest where the heart is located. So that's the sequence we are going to go. Cardiovascular examination is the pulse by checking the wrist.
Sir, we cannot see. You've muted your
Hello?
video. We cannot see it. You've muted your video.
Oh, sorry about that. Sorry.
Yeah, okay, you're welcome.
Okay. So we're saying that we're going to move in that sequence from we're going to move in that sequence from the wrist, where we'll be checking for the radial pulse. We'll now move upward to the arm, where we check for blood pressure. We'll now move to the neck, where we check for neck vein distension. After that, we move for the precordium. And I said that the precordium is that portion of the chest wall that is occupied by the heart. That is the precordium. Somebody will tell you, go and examine this person's precordium. You are not, if I tell you in exam, go and examine this person's precordium. I didn't tell you to examine the cardiovascular examination. I've just told you to examine just a portion of the cardiovascular examination. And that portion is the precordium. In other words, that portion of the chest wall, the portion of the chest that is occupied by the heart, examine it. That is the precordium. So that is the sequence we are going to go from the wrist, which is we are checking for pulse, then the arm, we are checking for BP, the neck, we are checking for neck vein distension, and then the precordium. So that completes our examination in that pattern. So, since you are going to be standing on the right hand of the patient, it means that you are going to be palpating the right wrist. That is the right radial artery of the patient, not the left. So that is the right that you will be palpating, because you are standing on the right hand. So you are going to be palpating the person's right radial artery with your own right hand. You use your right hand, you palpate at the person's right radial pulse. So as you can see in that picture that I sent to the group now, you can see that the examination consists of using the 3 fingers in the middle. I'm going to use what is it called now? The ring, I call it the ring finger on the right, the middle finger, and then the index finger. Those are the 3 fingers. You are going to use it, and you just press it at that particular position, just at the base of the right thumb, the right thumb of the patient. Have a right thumb. At the base of that right thumb, you press your 3 fingers in that base, and you are going to feel the pulse. You can check it with your colleague now. You can just check it. You will feel it. If you are paying up with somebody, you are with somebody there, just grab that person's finger, place your 3 your 3 fingers, the index finger, the middle finger, and the next one. Palpate it on the base of the person's right thumb. You are going to feel the pulse. Just obvious, clear. So that is the pulse examination. Then, fine, we're talking about the pulse examination. But look at here now. If you look at my screen here now, it said vital signs. Okay, vital signs, fine. We're going to put BP apart now because we are coming up to examine the BP. But what are we going to examine for the pulse? For the pulse examination, we are going to examine the rate, the rhythm, and the volume. Please, pulse examination is more than this. for your level now, I just want you to understand the basic. There are other things we are going to learn when we go higher to advanced level. But for this basic level, let's learn what is basic so that you don't get confused in the along the line when we start talking about the character, the bounding forces, and other things. You get lost. So I want to keep it simple at this level, but as we go on, we'll try to add more advanced things. So we're not going to talk more about the characters and other things. The simple thing you need at this point in time is the rate, the rhythm, and the volume of the pulse. I'm going to check for the rate. I'm going to check for the rhythm. I'm going to check for volume. Okay, that's another thing that I'm going to add, which is the synchronicity. The synchronicity. I'm also going to check for the synchronicity. Synchronicity means as you are palpating the right radial pulse, if we check for this rate, check for the rhythm, check for the volume, we also want to use the other of our hand to palpate the left radial artery. What do we want to ascertain by palpating the two radial artery at the same time? We want to confirm that at the same time we are feeling the right radial artery, we are also feeling the left radial artery. So if we are feeling both of them at the same time, we say they are synchronous. That is, there's no one delay. Because if we are palpating the right radial artery and we are palpating the left radial artery at the same time, and we're feeling the right radial artery after some seconds, maybe 5, 6 seconds, that's when we'll feel that of the left radial artery. It's telling us that they are not synchronous. So if they are not synchronous, it means something is delaying. Something is delaying the left radial artery from reaching at the same time that of the right is reaching. Both of them are not reaching that position of the artery at the same time. So something is delaying it. So what could be delaying it? We'll probably have an obstruction in some of the artery that is on the left side. Maybe what we call arteriosclerosis or stenosis of the artery, which causes the lumen to become occluded. Thereby, blood is not passing at that point of occlusion. So that's what we mean by synchronicity. Are we feeling the two pulses at the same time? So we have radioradial synchronicity, and we have radiofemoral synchronicity. So in radiofemoral synchronicity, we'll be palpating the right radial artery and the right femoral artery at the same time. So expect to feel the two pulses almost at the same time. When I say delay in the femoral pulse, it means that there is occlusion in the femoral artery. So the blood is not reaching the artery in time. So what could be that occlusion? Arteriosclerosis, stenosis, or trauma to the artery before, which has made the lumen to close a little bit. So blood is not flowing as fast as it's supposed to flow. So that's what we mean by synchronicity, radioradial synchronicity, or radiofemoral synchronicity. Okay, but the first thing, when we are palpating the right radial artery, the first thing we are going to check is the rate. How do we calculate the rate, guys? We simply palpate it as we are palpating that artery. You can do that on your friend now. Just put your hand on the person's radial artery. As you are feeling it, you start to count. Look at your watch. Put it in seconds. Count. 1, 2, 3, 4. You are just counting the pulse, but you are looking at the time in seconds. So you can decide to count for 60 seconds, which is 1 minute, because everything, the vital sign we check them per minute. So you can check for 60 seconds. The rate, which is the number of pulsation you feel in 60 seconds, which is 1 minute. The number of that pulsation you feel in 60 seconds. So you can count for 60 seconds. But if you don't have time, if you want to do fast, you don't have time, you count for 30 seconds and multiply it by 2. But if you still want to do fast, you want to do more fast, you can count for 20 seconds and multiply it by 3. Then if you have mastered the process, you are a master now, you can just count for 15 seconds and you multiply it by 4. So those are the method of checking for the rate. You can count just the pause, the number of possession you are going to fill. You count it just for 15 seconds and multiply by 4. Or you can count the number of possession you are filling. Just count it. How many possession are you filling? For 20 seconds, multiply it by 3. Or count the number of possession you are filling for 30 seconds and multiply by 2. Or just count the number of possession you are filling for 60 seconds. So any number you have, you just say the pulse rate is, let's say, 80 beats per minute. That's it. That's the rate. What is the rate? What is the pulse rate? 75 beats per minute. So if you guys have tried it, let me know, what did you get when you check your friend's phone? It's a practical class. Guys, comment on what you got on the pulse rate. If you have mastered it, let's move on. Tell me you have mastered it. Let's move on. You can drop in chat box. If you have mastered it, let's move on. If you have done,
yes, sir, we've done.
Yeah?
Yes, sir.
You have done it. You have mastered it.
Yes, sir.
All right. So that is how we check the rate.
Okay, sir.
The next thing we are going to check is the rhythm. What is the rhythm? What is the rhythm? The rhythm is telling us if that pulse rate we have checked, if it is regular or not regular. Is it regular or not regular? Regular means we are filling that pulse, and at the same interval, we are filling the pulse at that same interval. Beat, 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 beat. So we're filling that pulse at that same interval. That is regular. But if we are filling that pulse, beat, 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 beat. So it's not regular. So we can feel some pulse will just jump in, boom, 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 and disappear. If you are sick, you are still counting, another one jump in, beep, 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 and disappear. When we are feeling that type of that pattern, we say the rhythm is irregular. And when we come to irregular rhythm, we have what we call regularly irregular, and we'll have what we call irregularly irregular. Regularly irregular and irregularly irregular. So regularly irregular means there is a pattern. Let's say there's a pattern. Let's say we're having beat, beat, beat. We're having beat, 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 beat. Maybe after 4 beats, we now have beat, beat, beat. It disappears again. And then we now have again beat, beat, beat. After 4 normal beats again, we now have beat, beat, beat. So when we have that pattern, we said it is regularly irregular. So we can predict it. We can predict the pattern. We can predict that after 4 beats, we are going to have that irregularity. After another 4 normal beats, we are going to have another irregularity. After another 4 normal beats again, we are going to have another irregularity. That is regularly irregular. But what of irregularly irregular? Irregularly irregular means there is no pattern. We can't predict it. It beats, beat, 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 just like that. So we can predict it. That's not how we can predict that after 3 beats that it become irregular. So when we have that pattern, we said it is irregularly irregular. When we have a pattern we can predict, we said it is regularly irregular. We can predict it. Maybe after 3 beats, we are going to have an irregular beat. After another 3 beats, we have an irregular beat, just like that. So that is what the rhythm is telling us. So rhythm can be regular. Rhythm can be regular. It can be it can be regularly irregular. It can be irregularly irregular. So the next thing we are going to talk about in the pulse rate is the volume. So the volume can be normal. It can be low volume, or can be very high volume, which we call bounding pulse. It can be normal, can be low volume, can be a bounding pulse, which is very high volume. When you touch it, it's almost pushing your hand out. Pushing your hand out. So those are the 4 things we check in the pulse: the rate, the rhythm, the volume, the synchronicity. So the other ones are advanced. We'll get to that level, get to that point, but let's learn what is basic at this point in time. So let's entertain questions before we move ahead. Guys, if you have questions, ask. If you don't have questions, say no questions so that we'll move on.
No questions, sir.
No questions, sir. Please bring them up first.
No questions, sir.
No question.
Yes, sir.
Okay, so the next thing we're going to go, having done is having talked about the pulse, the whole thing we are going to examine in the pulse and all the rest of it is we're going to is the BP examination. Of course, we already talked about a little bit about BP now. I have said what is normal BP. So can somebody at least tell me what value of BP is considered normal? Hello guys, speak please. What is normal BP? What value is considered normal? What is considered abnormal? Okay, when do you say somebody has hypertension? At BP of what? Guys.
Sir?
I said it before that this class is going to be an interactive class. So, but you guys are making me,
to you, sir.
you're making me feel it's not interactive again now.
Normal BP is 120 to 80 mmHg.
Okay, so consider normal BP to be 120 systolic and 80 diastolic. Okay, fine. So when we still give a space of between for systolic between 120 to 140. So if we are using the old definition of hypertension, we call that pre-hypertension. It's somebody that's having a BP of greater than between 130 to 139. We call that pre-hypertension. We call definition of what is called hypertension is somebody that has a BP or systolic BP of greater than 140, or diastolic BP of greater than 90. If systolic BP is greater than 140 or diastolic BP is greater than 90, we say that person is hypertensive. Okay, so if you go to your page now, I sent the WhatsApp page, I sent 2 pictures about BP check. Who can tell me which one is correct, which one is wrong among the 2? I sent 2 pictures now on the WhatsApp page. I want you to open it up and tell me Among those two pictures that are showing BP check, which one is correct? Which one is wrong? Is it the first or is it the second?
The second one.
Second one is correct or wrong?
Second one is correct, sir.
Eh?
The second one is correct, sir.
Wait.
Why do you think it's correct? Why do you think it's correct?
Because
Eh? Okay, some little correction in that. And some little correction in that is if you want to check a patient BP, first of all, you must make sure that the hand is straight. Let the hand be straight. Let it not be folded. As this person is checking this BP now, there's a kink. There's a kink at the brachial artery. And that kink at the brachial artery, it can make the artery above, the artery before that joint. It can make the BP at where that curve is placed. It can make the blood pressure at that curve to be higher than normal because it is kinked. It is kinked. So you must make sure that the arm is straight. The arm is straightened. And then let the hand be a little at the level of the heart. Let the hand be a little at the level of the heart. Let it be straight. So those are the positions that you will need to apply, and make sure that you are using an adequate sized cuff. The cuff must be that of the size of the person, and let the hand be straight and at the level of the heart. So those are the precautions to check when you want to take your BP. Just always put it in practice. Let the hand be at the level of the heart. Elevate it a little bit at the level of the heart, and make sure that there's no fold, there's no flexion. Let it be extended. Let the hand be extended, and it should be at the level of the heart. So you check your BP, can check it on supine. The person is lying down. And also check it supine and why the person is lying down and why the person is sitting or standing, so that I can compare the difference. You can compare the difference. Okay. So can you see my screen now?
Yes, sir.
So those are the precaution about BP. So non-normal BP, 120/80. When we say a person has hypertension, person will have hypertension if the systolic BP is less than 90 or the diastolic BP is less than 60. 90/60, hypotension, 140/90, hypertension. So having said that, the next one we are going to look at now is the JVP. Let me check the JVP. The venous. I'm also going to send a picture of that, but let me check. Okay, look at it. You can see the screen. You can see the screen. Hello,
Yes,
guys.
sir.
Okay, so that is just what we need, for when it comes to the neck. All we just need is turn the head of the patient towards the left side, and we'll be able to look at that vein. That is called external jugular vein. So we're looking at how pronounced the external jugular vein is. So in some cases, we'll just put a little pressure palpating the abdomen, just a little pressure at the abdomen. Don't worry, you're going to watch the video of this. I'm going to put it for you to see how it is done, because I'm just saying this, but you watch the video, you'll see everything I'm saying. And I also try to send that video on the page so that you can watch it over and over again. So when you look at this JVP, This one is already elevated, but you can put a little pressure on the abdomen. That is what we call abdominojugular reflux. What we call abdominojugular reflux. When you palpate the abdomen, you are trying to put pressure on the chest, and that pressure will make this vein, the vein is already distended. It will make it to be more distended. It will make it to be more distended. Where do we see neck vein distension? Heart failure. You see heart failure. Heart failure, that's where we're going to see neck vein distension, as we have seen in this image we are seeing here. So we have covered the wrist, which is the pulse. We have covered the BP. We have covered the neck, which is neck vein distension. So the next place we are going is the precordium isthmus. Is the precordium isthmus. So, but before we talk about precordium, there are some landmarks that you will need to know. There are some landmarks that you will need to know before we talk about the precordium. And these are some of those landmarks that you will need to know. You see, this is a man that is simulating carrying a heart and putting it in its position, just to tell you that this is more or less where the position of the heart is, and the bony structures, which is shown up there. There are bony structures which is shown up there, and at the downside is just showing us the right atrium, the right ventricle, where we take the pulmonary artery, the aorta. So, and the important thing again for you to take note of in this image, I'm going to just explain some few things in the image, because I want you to understand some of the principles before we move on. If you look at in this upper image, where we have just the rib cage, we are going to see in this rib cage, we are going to see the clavicle. We are seeing the clavicle, it is labeled there. We're seeing the manubrium. But when we trace this manubrium down to the back, we're seeing the first rib is attached, the first rib that is attached. Then look at, if we come back here, come down a little bit here, where we're seeing angle of Lewis. It's important for you guys to get it here now. At this angle of Lewis, which is known as the manubrosternal junction. The manubrosternal junction, which is this, okay, here is labeled sternal manubrium junction, or also call it manubrosternal junction, which is the angle of Lewis. If you come down at that angle of Lewis, the next thing we are seeing there is the second intercostal space. So when we'll be assessing our apex beat, which is important to us, the apex beat, which is important to us, we are going to start at the second intercostal rib. So what we just need to do is to palpate the manubrosternal junction, and the space just down at that manubrosternal junction is our second intercostal space. So every counting that we are going to do when we're assessing the apex beat, we are going to start at the second intercostal space, because we don't have access to the first intercostal space. So we are not going to count or check the first intercostal space. We are going to palpate that manubrosternal junction. They will also, when you watch the video, you will also see that is where the counting will start. They will just palpate the angle of Lewis, which is the sternocmandibular junction, and the next intercostal space, just lateral to that junction, is the second intercostal space. So we'll start there. We'll count. We are going to count 2, 3, 4, 5, like that, because the first intercostal space is completely occluded. We don't have access to it. When we try to palpate it, we'll just be palpating the clavicle, because that space is it's just under the clavicle, so we can't palpate it. So the next thing we need to palpate is the sternocmandibular junction, and we move lateral to it. We'll now count the second intercostal space. From there, the third, the fourth, the fifth, like that, coming down. Okay, that is one of the important things here. The second important thing is, look at what we're having here. We're having the pulmonic valve. I think why we're having the pulmonic valve. So if we look here, just lateral, we're seeing the aorta. So at that point is also where we're having the aortic valve, because these are important things that we need to know the landmark, so that we need to know where we'll be placing our stethoscope. To place our stethoscope, what are we hearing? Are we hearing the aortic sound? Or are we hearing the pulmonic sound? We need to know, because we need to know the landmark. So that if we hear maybe a murmur, if we hear a sound, are we going to say this sound is coming from the pulmonic valve, or is it coming from the aortic valve? So that is why the landmark is important. So if we look at that heart now, this man putting the heart in the chest, we see where the pulmonic valve is. The pulmonic valve is at the second intercostal space on the left side, just at the sternal border, but at the left intercostal space, at the left sternal border. So we say this valve is located at the at the second intercostal space, left sternal border. That is what we're having there. Second intercostal space, left sternal border. So that means that is why we're going to put our stethoscope to listen for pulmonic valve, listen for pulmonic sound. Second intercostal space, left sternal border. What about the aortic valve? The aortic valve is located opposite to that position, which is the second intercostal space, right sternal border. So the pulmonic and aortic valve are opposite to each other. Second intercostal space, left sternal border. Second intercostal space, right sternal border. Second intercostal space, left sternal border for pulmonic valve. Second intercostal space, right sternal border for the aortic valve. So when we come back here now, when we come down to the second image on the right side, what we're seeing there is the mitral valve. So we can see where the mitral valve is located. We can see where the mitral valve is located. It's at the left side. It's at the left side at the fourth intercostal space. So that is where we're going to listen for any mitral sound. That's why we're going to listen for any mitral sound. Then the last one, which is, we're going to listen for tricuspid valve. We're going to listen for tricuspid valve at the, we're going to listen for tricuspid valve at the, between the fourth and the third intercostal space on the left side. Between the third and the fourth intercostal space at the left side, that is a tricuspid valve. But the mitral valve, we are going to listen for mitral valve, which is the last one we are going to listen at the place we are going to pick the apex beat, the apical beat, the apex of the heart. Who is lost? Who is confused here?
Sir, please maybe.
Ask your question. I'm using the image to orient you where you are going to be putting your stethoscope when you want to listen to the heart sound. There are 4 places you will be listening to. When we want to listen for heart sound, there are 4 places we'll be placing our stethoscope. We won't just be placing our stethoscope randomly anywhere we see on the chest. No. When you start placing a stethoscope on the chest of the patient randomly, your examiner will start laughing, because the examiner already know that you don't know what you are doing. You don't know what you are doing. The examiner will start laughing at you because you already know you don't know what you are doing. So for the examiner to understand that you know what you are doing, you must place the stethoscope at the right places. So that is why we're showing this image to show you the places. Later is also seen in another image, so that you know the places to, here, this one is better. So that you know the places you will place your stethoscope. At this image now we're seeing here now. if we look at this, this is the same thing with this image I tried to show you. But what I'm trying to show you here is where the valves are located, because the valves are what produce the sounds that you are going to be hearing. That lob dub, S1, S2, S1, S2, S1, S2. When you are reporting your heart sound, say S1, S2. Then if you have added sound, we said S3 or S4, which people also refer as S3 gallop, S4 gallop, which are additional sound that we pitch in people that have heart diseases. But now I want to learn what is basic, what is normal, because you need to know normal before you know abnormal. So first of all, I want to know where are we going to place our stethoscope. That's why I'm using this image to orient you where the valves are located. So the pulmonic valve is located at the second intercostal space at the left sternal border. The second intercostal space, just at the part that is closer to the sternum, that is where the valve is located. And the aortic valve is also located at the right intercostal space, the second intercostal space at the right side, right sternal border. So that is where you will put your stethoscope to listen for aortic sound and to listen for pulmonic sound at the second intercostal space, for pulmonic at the left sternal border and aortic at the right sternal border. So we have mitral valve. Mitral valve is actually located between the third and the fourth intercostal space at the left side. If you count the between the third and the fourth intercostal space on the left side, that's where the mitral valve is located. Sorry, the pulmonic valve, the tricuspid valve. I keep on saying mitral valve. So the pulmonic valve is second intercostal space, left side. Aortic valve is second intercostal space at the right side. The tricuspid valve is located at between the third and fourth intercostal space at the left side. Then we have the mitral valve, which is located at the apex of the heart. So using this image, we'll see what I'm saying much more better. The pulmonic valve, we see the dots, the black dot there. That where we see that black dot correspond to the second intercostal space at the left sternal border. Where we see the aortic area here is located at the right intercostal space, the second intercostal space at the right sternal border. So where they are putting this tricuspid valve is a little bit down, which is not really the correct position. The correct position comes a little bit up between the third and the fourth intercostal space. That is where the tricuspid is usually listened to. Then the mitral valve, or the mitral area, where they put the dot for the mitral area, is just at the apex of the heart. The apex of the heart is that part of the chest wall where you feel the cardiac impulse. When you palpate it, we are going to see what palpation of the precordium is now. When you palpate it, that part where you will feel the impulse, you feel the heart pulsating in your finger, just as you are feeling when you are checking the pulse. If you put the pulp of your finger on that part of the chest, you'll be feeling the pulse. You're feeling the pulse. So at that point where you feel that pulse is called the apex beat. So that is where you will listen for the mitral valve, for the mitral sound. Okay, so what we have here now is how to check the apex beat. So, but before we check the apex beat, we check what we call for murmurs. We check for what we call murmurs, which we put instead of putting the hand horizontally, we put the hand vertical, just at the precordial area, vertical. We want to check if there are heave, if there are what we call heave, in heave, we'll be feeling that the chest wall is pushing up, is pushing our hand up, is pushing our hand up in heave. As the heart is as the heart is pulsating, our hand is pushed up, pushed up. So when we see that, as we are putting our hand vertical, not horizontal, here we are checking the apical beat. That's why we are putting the hand horizontally. But when we want to check for heave, we'll put it vertical. So we feel that the heart, as it's beating, is pushing our hand up. And we see that in a patient that has systemic atrial hypertension. So in systemic atrial hypertension, the heart becomes big. Heart becomes big, the muscle becomes big. So as you place your hand at the surface of that precordium, the force generated by the heart as a result of the heart contracting, then to push your finger up. So we say the heart is heaving. We say the heart is heaving. So after heaving, we have to check for the apical beat, the apex of the heart, just by putting our hand horizontally. And this man is putting it. When we feel the pulse, when we feel the pulsation at our finger, we now start counting from the second intercostal space, as I have explained to you before. You count the second intercostal space, you come down, you palpate the third, you come down, you palpate the fourth, you come down, until you get to the point where you are feeling that pulse. If you get to the point where you are feeling the pulse, that becomes where the apex is located. Maybe fourth intercostal space, or fifth intercostal space, or sixth intercostal space. So from that point where we're feeling that pulse, we also trace it up to see where it will correspond at the clavicular area. Will it be at the mid clavicle? Will it be at the side? Will it correspond to the beginning of the armpit, the axillary region? Or where will it be? At the upside? Don't worry about this. You are going to watch the practical in the video. You will understand it much better. So from there, we are going to define where is our apex located. The fifth left intercostal space, mid-clavicular line, or the fifth left intercostal space, anterior axillary line, or the fifth left intercostal space, mid-axillary line. So that would depend on what we'll find just by palpating for the apex. So we're going to feel the pulse. When we place our hand at that position, we're going to feel the pulse of the heart pulsating. So we'll now come from the second intercostal space, come down until where we will now get that pulse. So that will becomes our where the apex beat is located. So what is normal apex beat? Where should the apex beat located in a normal person? It's the fifth intercostal space. It's the fifth intercostal space at the mid-clavicular line. Fifth intercostal space, mid-clavicular line. So in a patient that has heart failure, the apex beat will be displaced. That's what we call displaced apex beat. So most of the time, the apex beat might be located at the sixth intercostal space, anterior axillary line. It might be located at the seventh intercostal space, anterior axillary line, but it will not be at the fifth. It will come downward, down. Why is it coming down? Because the heart, in heart failure, the heart is dilated, becomes big and dilated. So where we'll be feeling the impulse will be lower than the fifth intercostal space, because the heart is dilated. Maybe at the sixth intercostal space or seventh intercostal space at the anterior axillary line or mid axillary line. So that is the apex beat. So after palpating for heave, then we'll palpate for the apex beat. After palpating for the apex beat, we just listen. We just listen with stethoscope. So that is the auscultation. We have done the inspection, which is looking. We have done the palpation, which we did for pulse. We palpated for pulse. We palpated for BP. We look at the vein, palpate the abdomen to see if the size of the vein will increase. So we now palpate precordium to check for heave and to check for the apex beat. So after that, we will now come to auscultation. So in auscultation, when you look at the stethoscope, you need to know the orientation of the stethoscope. The stethoscope has the bigger part, that part that you use to listen to the patient. We have the bigger part, which we call the diaphragm. And we have a smaller part, which is called the bell. We have the bigger part, which we call the diaphragm, and the smaller part, which we call the bell. When you want to listen for the heart or even for the lungs, we listen with the diaphragm, the bigger part. The bigger part is meant to capture a loud sound. The smaller part is used to capture a sound that is not ordered loud. Let's say you use the diaphragm now to listen to the heart sound, and the heart sound was faint. You couldn't hear it very well. It was distant. The sound was just small. You couldn't pick it. So what you need to do is to rotate this your stethoscope. Just rotate it to put it at the bell. So you now use the bell to listen. When you use the bell to listen, the sound will become more clearer. It become more clearer. So we use the bell to listen a smaller sound. But normally you must listen with the diaphragm first. If the sound is small, that you hardly pick it, then you turn your stethoscope to use the bell. There's a way we rotate it. Just grab it at the part that connects to that diaphragm and just rotate it leftward or rightward. You see it move. When it moves, see where it will not stop. It tells you that it has changed to bell. So you now use the bell to place on the chest wall to capture the sound if the sound is low. So this one is complex. Don't worry about this one. This one is just activity of the heart, how it's being captured and how it's being displayed to move with electrocardiogram, ECG. I believe most of you guys have seen ECG at the hospital. So it's just an image that coincides the heart sound where we have those valve and the sound, where it coincides with ECG that the machine will pick. And these are the sounds that we have. We have the S1, we have the S2, lob dub, lob dub, lob dub, lob dub, lob dub, lob dub. So the S1 corresponds to when the tricuspid and the mitral valve, when they are closing, when the tricuspid and the mitral valves are closing. The S2 corresponds to when the aortic and pulmonic valve are closing. Aortic and pulmonic valve closure. That's what they connote. S1, mitral and tricuspid closure. S2, pulmonic and aortic closure. So that is why here, when you look at this image here now, where you see S1, S2, in the other image where they wrote inspiration, you see it being represented. You only see S1, but the other one you see A2, P2. What does A2, P2 stand for? A2 is just another way of representing S2, S1, S2. This is first heart sound is S1, lob. Second heart sound is S2, dub, lob, dub, lob, dub, lob, dub, lob, dub. First heart sound S1, second heart sound S2, lob, dub, lob, dub, lob, dub, S1, S2, S1, S2, S1, S2. Then when we come to the S1, like I've said before, it's generated by tricuspid and mitral valve closure. So these two valves tend to close almost at the same time. But when we come to S2, which is generated by pulmonic and aortic valve closure, there's a little delay. That's a little delay. The aortic valve tend to close faster. That is the A2 than the pulmonic valve. But when we still listen, what we still listen is S2. That little delay is not enough to be appreciated when we listen. So we don't see it split, like as they have stated here. It doesn't split when you listen it with your ear. You are still going to hear lob dub, lob dub, lob dub, S1, S2, S1, S2, S1, S2. S2 is created by aortic closure, A2, and pulmonic closure, P2. So A2 represents aortic closure, P2 represents pulmonic closure, S1, S2. The A2, P2 represent S2. That's what they represent. So these are wrong techniques that I want to show you when you are listening to the heart sound. You shouldn't take a stethoscope and you don't put it on the top of the cloth of the patient. Don't. It's not correct. And look at this person, you carry stethoscope and putting on top of bra of a woman. You are not going to listen anything. You are not going to hear. You are not going to hear anything when you put it on the top of bra. So this is the right thing to do. You must expose and look directly on where you are placing the stethoscope. Expose, look at where you are placing the stethoscope. So you can see the first place we are placing the stethoscope is the aortic area. So that's the first place to listen to. So we listen to the aortic area. After that, we listen to the pulmonic area. So after the pulmonic area, we listen to the tricuspid area. After listening to the tricuspid area, we listen to the mitral area. So in all, what we're going to see here is lobed up, lobed up. If you listen to pulmonic area, we hear lobed up, lobed up. Listen to the pulmonic area, we see here lobed up, lobed up, S1, S2. We listen to the tricuspid area, see lobed up, S1, S2. To the mitral area, the same thing. Just that if we now listen to the pulmonic area, listen to the aortic area, and after that, we remove the stethoscope, listen to the pulmonic area. We might find that the sound is louder at the aortic area than the pulmonic area. So, but that is a pathology we'll talk about later, much more later when we'll be talking about other things. But this one is basic. Just know the basic for now. So, as we are listening to here, we can also pick murmur. Most of the time, murmur is heard as few. As you are listening, you are going to be hearing few. Sometimes it look like a respiratory sound. Maybe somebody that is breathing, the sound you hear when somebody is breathing. So you hear a murmur in people that have heart pathology. So that is it, how to listen to the heart sound and the places to listen to. The aortic area, the pulmonic area, the tricuspid area, and the mitral area. So after that, after listening, auscultating for these 4 places, the last thing we do is to listen at the lung basis. So when we listen at the lung basis to see if there is congestion, if there is fluid in the lung basis, that completes the cardiovascular examination, the basic cardiovascular examination. So how are we going to report it? We report it. The pulse rate is, let's say, 80 beats per minute. It's regular. It's normal volume. There is radioradial synchronicity and there is radiofemoral synchronicity. That is it for the pulse. The next thing we report is the BP. The blood pressure is 160, 100 millimeter mercury. That is it for the BP. The next thing we report is the neck bends. Okay, the neck bends are distended. Just in that sequence, we did it. The neck bends are distended or no neck vein distension. After that, we're now coming to the pericardium. We said the apex beat is at the 50 left intercostal space, mid-clavicular line. It's not heaving. We now come to the heart sound. Heart sound is S1, S2, and there is no murmur. That is it. We have finished reporting our cardiovascular examination. I'm going to put it on page. This what I've just said now. I'm going to put it how the reporting is done. So that completes the theoretical aspect of this class. We'll now watch the video. Hello guys, are you guys there? All right, if you are there, just signal that you are there. If you are hearing me, just signal that you are hearing me. If there is a question, just also ask the question now. Hello, Esther. If you are there, please. If you can hear me, tell me you can hear me. You can type if you can hear me. Just type that you can hear me. Okay. Any question? Please ask question. Ask question while I put the video on now just to play. The video is not much, it's just 12 minutes. 12 minutes video on cardiovascular examination so that you master it. I will also post it on the page. No question with all of these classes. Eh? No question. So is it that the class is so simple or it's so complex? Which one? It's difficult to believe there's no question. Okay, so I'm trying to play the video now. I'm going to, let me go to the file. I just hope, let me see if let me just start playing it. Then I will do this thing. I will show my screen so that it will be smooth. Please, while I do this, if you have question, please ask question. Let me see. Just okay.